Good afternoon, and thank you for rejoining us and being here with us in this room. Lots is going on, many interesting parallel sessions, and of course with parallel sessions come choices. But the next hour is going really to take us to a deep dive on the topic of can people afford to pay for healthcare? As I said in the opening yesterday, we launched for Universal Health Coverage Day our financial protection report produced by colleagues at the Barcelona office, who I will introduce in a minute, covering data from 40 countries across the region. Data that reminds us that this is a topic that, although in 2008 a number of countries signed up that it was unacceptable for people to become poor as a result of ill health, across the European region we still have an unfinished agenda and lots of work that remains to be done. And in order to really have a good discussion on this topic, I will be joined by my co-moderator Trin Habit, and you will first kick off by having a presentation and unpacking the rich findings. The head of the office in Barcelona, Tamas Evitovic, and Sarah Thompson, the lead behind the financial protection report. So, over to you.
Thank you, Natasha. 5 years ago, we presented the first ever regional report on financial protection here in Tallinn, using evidence from 24 countries. Now we are here to present the second report using most recent comparative data, pre-pandemic data from 40 countries across Europe. 15 years ago, evidence on financial protection for most countries was a black box, non-existent. We had very few data about financial hardship in countries, except for a few countries like Estonia, which did diligently monitor financial protection already back then. Now we are literally in the black box, inside the black box, and we have the answers to these key questions. How many people face catastrophic or impoverishing out-of-pocket expenditure? Who are they? And what drives financial hardship? No countries in Europe have achieved universal health coverage yet, because all countries have people who face financial hardship and unmet need. Is it acceptable that people become poor as a result of ill health? The Tallinn Charter had a clear answer. No, it's unacceptable. But still, this is what we see. Incidence ranges from 1% to all the way up to 12% of households facing impoverishing out-of-pocket payments for health. The health system is contributing to increasing, not decreasing, poverty. The incidence of catastrophic out-of-pocket payments across Europe ranges from under 2% in Slovenia, Ireland, UK, Spain, and Sweden, all the way to 20% in Bulgaria and Armenia, with a median of 6%. These are already very high numbers. But once we look into the distribution, which is what really matters, what we see that it is people in the poorest households who are most likely to experience catastrophic health spending. Here on this chart, you see the dark blue bars stand for the incidence in the poorest 20% of the population. And the median jumps up to 20%, and the worst performing countries reach 60% of those who are in the poorest 20% of the population. These are shocking numbers, not only unacceptable, but shocking numbers. How much out-of-pocket payments for different services in the EU? On this chart, you see the dark gray part of the bars that stands for public spending on health. The light gray, the lighter part, is voluntary health insurance. Just note how little that is and the colored part of the bar charts are for out-of-pocket payments for these services. Outpatient medicines at 40% of total spending on outpatient medicines. Medical products and dental care reach 60% of out-of-pocket payment. What drives then financial hardship for these people who face catastrophic expenditure? Here on this chart, what you see is the composition of services that are responsible for the catastrophic incidents in these countries for the people who are facing catastrophic spending, ranked from lowest to the highest incidence, the same chart as before, but now we are zooming into the composition of the different services that drive financial hardship. What you see that on average, households with catastrophic spending are mainly paying for medicines. Also a bit on dental care, which is blue, and medical products, which is the orange. But again, once we zoom into the composition of the services for the poorest fifth of the population, then this becomes almost everywhere red, meaning it's medicines that drive financial hardship for poor people. Poor people prioritize medicines over other services, which become unmet need, for example, dental care for them. What really matters here is that, and this is what we see, that most of the services that are responsible for financial hardship are actually services that are taking place in primary care settings, treatment in primary care settings. Why is it that we cover medicines for inpatient care, but once the patient leaves the hospital, the very same medicine becomes a burden on the patient? And I'm not suggesting that we should not cover medicines while you stay in hospitals. The point here is that there is no argument in favor, especially for chronic conditions, especially for people with low income and frequent users of healthcare. So financial hardship is mainly driven by out-of-pocket payments for treatment in primary care settings, one of the key messages of the report. And the last chart from me is this potentially one of the most important charts, this strong correlation between the incidence of catastrophic expenditure and the share of out-of-pocket payments of the total spending in countries, a data which is available to all countries. Not the catastrophic incidents, but the share of out-of-pocket expenditure. And what we see here is that if countries can manage to keep the out-of-pocket share of total spending below 15%, then the incidence tends to be relatively low and with little variation. Once it's more than 15%, the incidence rise sharply and with a lot of variation. No magic number here, but a very good proxy for strong financial protection if you don't have the data on catastrophic incidents and impoverishing incidents. But we do have the data, at least for the 40 countries here. The variation here suggests that it's very important to focus on protective coverage policies, and that's the message of the report. Public financing is a key contributor to strong financial protection, but increasing spending publicly alone may not do the trick. We need to have strong protective mechanisms for chronic condition patients, for people with low income, and with people who are frequent users of healthcare. So with that, I hand over to Sarah now to tell you the story behind the numbers and highlight the key policy choices that need to be avoided, and also the good practices to follow. Thank you.
Thank you very much, Tamas. In our report, we have a really strong focus on policy analysis because it's the policy analysis that gives us the story behind the numbers. We have a particular focus on coverage policy. This is the way in which health coverage is designed and implemented in countries. And we focus on coverage policy because it's a key determinant, not just of the level of out-of-pocket payments in a health system, but of the distribution of those out-of-pocket payments across the population. This is super important because if we know who is affected by out-of-pocket payments and how they're affected, then we can identify where the problems are in health systems, and we know where to focus if we want to address those problems. In our report, we highlight 5 coverage policy choices that we want countries to avoid because they undermine financial protection and they slow a country's progress towards universal health coverage. They do this because they are unfair. They have a disproportionately negative effect on households with low incomes and households with chronic conditions. They're also inefficient. They increase inefficiency in the use of healthcare. And they weaken resilience. They weaken the resilience of households and of the health system to economic and health shocks. Most of these coverage policy choices are not really based on evidence. So why is it that we see them so frequently across countries in our study, but across countries in the whole of the European region? Is it because policymakers don't understand evidence or are not willing to act on it? What we see in our report and our analysis is that often it's because this is the way that countries have always done things. And there's an element of path dependency here. Once you're on a path, it can be difficult to get off that path and to change track. But in our report, we also show that progress is possible. We look at policies, coverage policies that are working in countries with a very low incidence of catastrophic health spending, and we use this analysis to propose a checklist for policymakers. We identify some good coverage policy choices that countries can make if they want to strengthen financial protection and make progress towards UHC. And those are the 5 coverage policy choices that I'm going to focus on in the next few minutes. Coverage policy choice to avoid number 1. This is linking entitlement to payment of social health insurance contributions. This chart here shows you the share of the population that has access to the full range of publicly financed healthcare in a country. To be covered, there are 2 main paths to coverage. The first is by being legally resident in a country. The basis for entitlement is residence, and these are the countries on the chart that are in blue. The second basis for entitlement is when you have to pay contributions to a social health insurance scheme, mandatory contributions, or the government pays contributions on your behalf because you're a child or a pensioner. And in order to access the full range of publicly financed health services, you need to pay these mandatory contributions. And these are the countries in red on the chart here. The chart is divided into 2 sections. On the left, these are the countries that cover over 99% of the population. Most of them cover or report covering 100% of the population. There's a nice mix of red and blue columns in this side of the chart. But on the right-hand side of the chart, you can see that it's overwhelmingly red. These are the countries that cover less than 99% of the population. And these are countries that link entitlement to payment of social health insurance contributions and probably have a large informal sector, probably also have weaknesses in the way in which they collect taxes from people and businesses. You can see that this coverage policy choice leads to really visible gaps in population coverage, really quite large gaps in some of the countries on the right of the chart here. It's unfair because it mainly affects people with low incomes. Often these countries have large informal sectors, and it's people who are in informal, precarious work, temporary, insecure, usually poorly paid. These are the people that are excluded from coverage because of this coverage policy choice. It's also inefficient because these people who are not covered are forced to rely on emergency care, which is much more expensive for the health system, or they simply forego care and experience unmet need. And ultimately, it weakens resilience too, because people may lose coverage just at the moment when they need it, when the economy is declining, when they are losing their jobs or their wages are being cut. It also undermines financial protection. And if we map the incidence of catastrophic health spending onto the chart here, you can see that in the countries on the right, where they have these larger gaps in population coverage, the median incidence of catastrophic health spending is 3 times higher than it is in the countries on the left, where over 95, 98, 99% of the population is covered. So this strongly suggests that being covered, universal population coverage, is a prerequisite for financial protection. But it's not a guarantee, because you can see that even in the countries on the left-hand side of the chart that cover 99 or 100% of the population, some countries have a very high incidence of catastrophic health spending. And this suggests that it's other coverage policies that also play an important role in protecting people. So this coverage policy choice is highly likely to undermine trust in the health system. This is something that we've heard about a lot in the last 24 hours. When countries link entitlement to payment of contributions, they are essentially saying that if you don't pay your mandatory contributions, which are effectively taxes, then we are going to punish you for non-payment of taxes by denying your access to publicly financed healthcare. So they're using the health system to address what is fundamentally a tax problem, but there's absolutely no evidence to show that this is a successful or effective strategy. And so our first good practice recommendation is that countries, de-link entitlement to publicly financed healthcare from payment of social health insurance contributions. Let the tax agency deal with what is fundamentally a tax issue, non-payment of contributions and taxes. It shouldn't be the responsibility of the health system to do this. In our report, which has many case studies showing progress is possible, one of them is France, which in 2000 changed the basis for entitlement to its social health insurance scheme benefits from employment and payment of contributions to residence. A very good example for countries to follow. And in the panel discussion that follows, we're going to hear from Alyona about Ukraine, which managed to avoid introducing this link, even though it came under quite a lot of pressure to do so when it was reforming its health financing system in 2017. So progress is possible. Changing the basis for entitlement doesn't mean that you have to change all of your other health financing arrangements either. The second coverage policy choice to avoid is excluding people from coverage. The policy choice I've just talked about, linking entitlement to payment of contributions, implicitly excludes some people from coverage. But many people, many countries also explicitly exclude people from coverage. And often it's undocumented migrants and sometimes also refugees and asylum seekers, something that is highly topical at the moment. This doesn't create such a visible gap in population coverage because these three groups of people are usually a very, very small share of the population. But also because countries tend to report covering the whole population even when they don't actually cover these groups of people. And this table here shows you entitlements for undocumented migrants across the 40 countries in our study. And you can see that in many countries, their entitlements are really limited to emergency care and control of communicable diseases, so very, very limited access to healthcare. Refugees and asylum seekers tend to have slightly better entitlements than undocumented migrants in many, but not all countries, but they often face barriers in accessing health services. Again, the group of people affected by this coverage policy choice are people, generally speaking, with very, very low incomes. And it also adds to inefficiency in access to healthcare because people are forced to use emergency services, which is more expensive for the system. So our second good practice recommendation is that refugees, asylum seekers, and undocumented migrants should be entitled to the same benefits as other residents. And in our report, we have a very good case study of Spain, which does just that, and is even, as we speak, trying to remove administrative barriers that these people face to accessing entitlements. Coverage policy choice to avoid number 3. This is applying user charges or co-payments without having effective protection mechanisms in place. There's a really large body of evidence globally that shows that user charges are an inefficient way of getting money into the health system. They tend to reduce the use of necessary as much as unnecessary care. They deter people from using health services that we want them to use. They reduce adherence to medicines and other forms of treatment. They increase financial hardship. They increase the use of other services that may be free at the point of use. And they increase the use of social assistance. But in spite of all of this negative evidence about the impact of user charges, many countries in our region have user charges for some or all health services. This chart just shows you the application of user charges across the 40 countries in our study and across the different types of healthcare. Two interesting things here. The first is that countries clearly realize that user charges can be a deterrent to access. And so some countries try very hard to protect primary care visits from user charges. And in 60% of the countries in our study, access to primary care visits is completely free of charge. But when it comes to the things that Tamas was mentioning earlier, when it comes to treatment in primary care settings, medicines, medical products like hearing aids, and dental care, this is where countries, generally speaking, apply user charges. So an interesting attempt to protect primary care visits, but not transferring this to treatment in primary care settings. And this is one reason why these types of healthcare are such an important driver of financial hardship and unmet need in Europe. So many countries have user charges already. Is there anything that countries can do to mitigate the damage potentially caused by user charges? Yes, there is. Our analysis shows that the way in which you design your co-payments really can make a difference. This chart shows you the incidence of catastrophic health spending across the 40 countries in the study. And in the countries on the left of the chart, these are countries that try very hard to protect some people from user charges, using a mix of protection mechanisms, so exemptions based on income, caps based on income, using low fixed co-payments that are flat rates, so very transparent, easy for people to understand, very simple. On the other side of the chart, these countries also recognize the damage that user charges can do, and they also have protection mechanisms, but many of them are not as effective as they should be. These countries also rely very heavily on percentage co-payments, which is where people pay a share of the cost of a medicine or a health service. And percentage co-payments have a lot of disadvantages compared to low fixed co-payments. They're unfair because if you have a disease that has more expensive treatment, you will have to pay more out of pocket compared to somebody who's lucky enough to have a disease that has cheaper treatment. They're very non-transparent. It can be really difficult for people to know in advance how much they have to pay when they go to the pharmacy to get a medicine, or they go and see a doctor, or they go to hospital. They're also more likely to expose people to inefficiencies in the health system, because if the price of medicines is not well controlled, if prescribers and dispensers don't have strong incentives to dispense and prescribe the cheapest medicines to people, then it's people paying out of pocket who will bear the financial risk of those policies. So our third good practice recommendation is that user charges, if they are applied, should be applied sparingly and very carefully designed. So people with low incomes, people with chronic conditions should be exempt not just from co-payments for those chronic conditions, but from all co-payments. And these exemptions should be applied automatically. There should be an annual income-based cap on co-payments for everybody. Again, it should work automatically. There shouldn't be any percentage co-payments. There shouldn't be balance billing or extra billing. These are really non-transparent forms of user charges that can be very detrimental to people using health services. And lastly, people should really know in advance exactly how much the system asks them to pay at the point of use. In our report, again, we have many country examples. We show that progress is really possible if countries monitor their co-payments and adjust them as they go along. And part of the transformation of this comes from the use of digital solutions. And in the panel discussion afterwards, we're going to hear a little bit about how Estonia has been using digital solutions to do just this. The fourth coverage policy choice that countries should avoid is failing to cover treatment in primary care settings. I think we've talked a lot about this already, but by treatment in primary care settings, I mean medicines, medical products like hearing aids, and dental care. As we saw, these are the three things that are really driving financial hardship, particularly medicines for households with low incomes. Tamas showed you this a little bit already, but out-of-pocket payments really affect people differently. This chart is the breakdown of out-of-pocket payments by type of healthcare among households with catastrophic health spending. And it's two things that I want to point out. The first is the blue, which is dental care. And you can see that out-of-pocket payments for dental care really seem to be driving financial hardship, mainly for richer people. And this is because poor people cannot even find the money to pay out of pocket to see the dentist, and they experience unmet need instead. But when it comes to medicine is much more out-of-pocket payments for medicines are much more likely to drive financial hardship for poorer households. And we know from other survey data that poorer households are much more likely to experience unmet need for prescribed medicines as well. So a real double whammy here of financial hardship, more unmet need for households with low incomes because of out-of-pocket payments for medicines. So our fourth good practice recommendation is that these services should be part of comprehensive, multidisciplinary primary healthcare coverage, and they should be affordable for everybody. Making these types of services affordable for everybody probably means, in some countries, making sure that the whole population is covered. It also means that these services are included in the benefits package. And finally, if you have co-payments for these services, it means designing them really carefully so that people with low incomes and people with chronic conditions don't have to pay at the point of use. Our fifth and our final coverage policy choice to avoid is thinking that voluntary health insurance is the answer. It can be very tempting for policymakers, particularly in countries where there's a really strong budget constraint, to think it's very, very difficult to increase public spending on health. So perhaps we can allow voluntary health insurance to step in and do the hard work of reducing out-of-pocket payments instead. Well, unfortunately, the international evidence on this is very clear that voluntary health insurance across countries really does not do a good job at reducing out-of-pocket payments. There's a very, very weak relationship between how much countries spend through voluntary health insurance and how much they spend through out-of-pocket payments. There's a much, much stronger relationship between how much countries spend publicly on health as a share of their GDP and the relationship, the reliance on out-of-pocket payments. So I think the clear message here is that if you really want to reduce out-of-pocket payments, voluntary health insurance is not the way to go. You can't do it without more public spending on health. So our fifth and final good practice recommendation is that coverage policy should be supported by adequate levels of public spending on health. But it's also really important that if you have additional public funds for health, that you spend them first on the people who need most protection, so people with low incomes, people with chronic conditions. This is one way in which to make progress, even if you have very, very limited fiscal capacity. And in any context, it's a way to begin to build resilience for households and health systems to economic shocks. So Tamas and I have given you an overview of some of the key findings from our regional report. It's available online. We hope that you will read it. All of the data in our report is now available online too, in a new platform that we've developed called UHC Watch, which is designed to track progress on affordable access to healthcare in Europe and Central Asia. And before I hand you back to Natasha, I'm going to invite you just to watch a very, very short film on UHC Watch, which will show you, we hope, how it can be useful to you, and we very much look forward, as users, to your feedback on how we can improve it. So could we have the film, please?
As we work towards universal health coverage, or UHC, we need to ensure that healthcare is accessible and affordable, so that everyone is protected from financial storms. Affordable access to healthcare is known as financial protection. It is not only critical for UHC, it is a sustainable development goal. Countries across Europe and Central Asia have made good progress towards UHC, but many people still experience gaps in coverage. This means they face barriers to access or have to pay out of pocket for healthcare, sometimes at the expense of other basic needs. In this way, out-of-pocket payments can push people into poverty. We need to find ways to reduce these payments, but we can't do that without the right information on where and why things are going wrong. We also need to know what to change to make things better. This is why WHO Europe has created UHC Watch, an online platform with data and analysis on unmet need, financial hardship, health spending, and coverage policy in countries across Europe and Central Asia. Designed for policymakers and advisors, academics, journalists, and civil society advocacy groups, UHC Watch makes it easy to find the evidence, resources, and good practice recommendations you need. You can visit the country profiles for a snapshot of who experiences unmet need and financial hardship, and the health services and policies that are responsible. You can use the indicator and policy explorers to get a better understanding of the current situation and to monitor trends over time. You can generate your own analysis, comparing indicators and policies across countries, and exporting data and graphics. UHC Watch has the evidence and analysis we need to move us closer to universal health coverage. UHC Watch, tracking progress on affordable access to healthcare in Europe and Central Asia.
So thank you very much, and I think Tamas and Sarah need a stronger round of applause. And as you have seen on the screen behind us, allow me also to take a moment to kindly acknowledge the financial support that we have received from DG Santé, its financial support, and of course, lots of conversations that are taking place to achieve this common objective that is shared widely across and we align on in terms of really trying to ensure that we have all the data and evidence to inform policymakers. And we are pleased to note that this data is also feeding into other reports, such as the OECD Health at a Glance report, but is also then being used, for example, when country-specific recommendations are being drawn up in the context of the European semester. It gives us really much joy to be able to see the use of evidence in policy. And now we come to the second part of the session, our panel discussion. And I would like to invite Tamas and Sarah to join us again on stage. And I would like to introduce our country panelists, Andres Vok from Estonia, who has been leading on the financial protection work in Estonia, Alona Goroshko, who has already been mentioned by speakers. She has been leading on the work in Ukraine, and Kenneth Grech, who is leading on the financial protection work in Malta. And now I would like to hand over at this point to Trin.
Thank you so much, Natasha, and thank you, Sarah and Tamas, for this introductory presentation. And we are really lucky to have you here, Kenneth, Alona, and Andres. And let me start with Andres first. It's because I think Estonia is one of the countries in the region which has been analyzing financial protection probably for the longest time, maybe even. So it's you, Andres. You are that person in Estonia who has been starting that work, I think, believe it, more than 15 years ago, or maybe already 20. And now also, like yesterday, we launched the update on Estonian financial protection situation, and then you are the lead author of that as well. So you have all the, like this memory. So how this analytical work, all these reports published, what actually has been impact? So it's on policy making. So it's because we all know that it's really nice to do all this analytical work, but it's much more difficult to have the real impact. And maybe you have some, like it's a story to tell, because we have limited time, so we could discuss that probably for hours. But maybe just one example, one area where you see the biggest impact in Estonian policy making.
Excuse me. Thank you, Doreen. Indeed, Estonians love to write reports on financial protection. Yeah. So when I started to count these yesterday, I counted that with the help of WHO, we made 8 reports or studies since 2006. The first one was actually published by Jarno Haabich together with Shuka and Joe Gutson. So initial reports were with the help of them. And then later, of course, with the help of Sarah, Tamas, and John, yeah, we have made these reports. And now you might ask, did it actually paid off? Yes, of course it has. I'm here on the stage, yeah. So, but to be more kind of serious, I think it has kind of contributed at least 3 things. First, of course, every new study that we had made had kind of helped us to keep the topic in the agenda of the policymakers. So again, we had the new results, and of course now we have cross-country comparative results. Yeah, that's even more important. And I think what makes it kind of more specific is that every report that we made had also very specific recommendations. It wasn't kind of an academic exercise, which I also love to make as a lecturer, but we tried to give specific recommendations. And if you ask about one area, then I think I would pinpoint pharmaceuticals. I think the first study already that we made in 2006 showed that pharmaceuticals are the main, let's say, the main item that drives catastrophic expenditure. And we kept saying that for years. And then on parallel of that, we saw the improvements in the coverage. Okay, of course, I'm kind of being an author of that. I can't say it's kind of related directly, but or I shouldn't say, but in 2007 and 2008, we had a really policy of kind of using more generic drugs. We had these active ingredient-based prescriptions. We have campaigns. And up to the point in 2017, we had a change in the co-payments. We had this automatic reduction in co-payments if you reach a certain level of expenditure, so thanks to IT technologies. So I think we have contributed at least a little bit to overall reduction in these co-payments, together with, I mean, of course, with international colleagues. Yeah, thank you.
Yeah, absolutely. And then you can find on your table this short press practice brief on how Estonia has been using digital technologies actually to improve access to the benefits, and what Andres was just mentioning. And I can really reflect also, like it's from my side, because I was not in the university at that time, but I was working in 2006 and after that in the House Insurance Fund. And I do remember the change in the mindset that it's really not like a house insurance fund's job is not only to think about how to make sure the public funds are spent well and that you stick into your budget, but we should also care about how much people need to pay in addition to that. So it's really like and especially like, as you said, it's medicines are the area where people need to contribute a lot. And of course, initially, it kind of seemed also like a nice way how to stick into the budget. But that's really not the way how we should think if we keep in mind universal health coverage. But, Andres, you have been doing that like it's for years. If we look the data, then we still see that if we look at catastrophic health spending, then there is some improvement, but it's not a huge improvement. And if we look inside it, we see that more than half of those households who are facing catastrophic health spending, these are the poorest quintile. So do you have any, like, it's good news on that? Is Estonia really thinking on really targeting those who are most in need? Or it's something that we as our Estonian minister said earlier, that we are still like it's applying our policies and just hoping that maybe this time it works.
Yeah, indeed. I think Estonia, what we can do is actually to target better. I mean, in general, out-of-pocket payments, they have about more than 20% of health expenditure in form of out-of-pocket payments. But I think that's not the only issue, is that we really don't target these policy measures because we don't have any caps, overall caps in out-of-pocket payments. We don't have out-of-pocket payments, or let's say co-payments are not related to household income, although we have now a new measure. Let's say dental care benefits are larger for households who receive means-tested benefits. So we can have kind of an indirect link between household income and the benefits the household gets. But that's the only case we have. But it is done, and it's done digitally. So we have all the registers. And I think that we could expand that experience, I mean, to other areas. So we should introduce overall cap on out-of-pocket payments, not only at individual level, but also household level, I think. And that would, let's say, we could kind of use the same resources much more efficiently.
Yeah, absolutely. And let's keep our fingers crossed that this is just a first step, and that's will be encouraging first step. That we really see that this type of policies can be used much more widely. And I very much hope that yesterday published financial protection update will feed into this policy dialogue. But let me now move to Alona. You had a long journey from Kiev to Tallinn. The distance is not long, but it does take time to travel now. You have been also the lead author of 2 financial protection reports for Ukraine. The first report really was a baseline report before introduction of large-scale house financing reform in Ukraine. That was started, the implementation started in 2018. And now, this June, during the Financial Protection Forum, we launched the second report that tried to capture, what has been the effect of this reform, that implementation was already ongoing on financial protection. And could you tell us a bit, because what Sarah also mentioned, that Ukraine was very smart in preventing that. Part of the health financing reform is to link entitlements to the payment of contribution. So could you open us a bit, was it an easy policy choice? Did it came naturally? And maybe also what effect you do see on financial protection. So because the recent report really has the data up to 2021. So really, it captures some of the effect of the reform.
Thank you. In Ukraine, we had a discussion on whether we need to implement social health insurance schemes for over 20 years. So it was a very long discussion. We had 21 draft laws prepared by different people to try to implement payroll tax and to link it to entitlements. And when our team started working on the health financing reform, we analyzed those draft laws. And we saw that some of them were motivated by private interests, some of them were just following the trend or maybe the fashion of introducing the social health insurance, but none of them focused a lot on how the money will be used, actually, so how the purchasing will be organized. So they were mainly focused on how the different stakeholders will pay different share of taxation, etc. And none of these laws actually had a very good arguments on why that would be more efficient to introduce payroll tax compared to general taxation. So in 2017, the law which introduced the new financial arrangement was adopted. It continued the system that Ukrainian healthcare system relies on general taxation. And I think what worked for that law compared to 21 laws which were about to introduce social health insurance, there were several factors. First is that the team suggested the comprehensive system with resource generation, pooling, and purchasing being addressed in the one document. Second, we teamed up with finance people, and that worked well because together we were able to show that additional taxes will not result in what we want to see in the future healthcare system. And third, we also teamed up with very good communication people who helped us to shape our messages on why we need to introduce specific health financing changes, because it's a very technical discussion which is rarely interesting to people in the parliament or to high-level government officials. So, and that wouldn't have worked if we were just discussing national level pooling is much better because of this technical arrangement. So we teamed up with these communication people, and they actually helped us to shape our arguments around improvement of financial protection of population. And back then, in 2016-17, we haven't had the data to show how bad financial protection is in Ukraine, but we knew that with our level of out-of-pocket spending, which is about half of total health expenditures, we definitely have something bad happening there. So we used this as a one of the key arguments that we need to change our financial arrangement. And now, having these two reports, we see that it actually worked, and financial protection slightly improved, and we attribute it to the health financing reform. We also see that informal payments decreased for some of the priority services, and access to outpatient medicines improved also as a result of those reforms. So we see it worked that way.
Thank you, Alona. And I think that's really like it's interesting example where we see that it's good for health sector to actually team up with Ministry of Finance. And Ukraine is not the only country where, when it comes to really discussion whether it should be a contribution-based social health insurance or general tax-funded system, that actually Ministry of Finance can be the best ally in these discussions. But of course, like if we think about this health financing reform, Ukraine implementation started in 2018. Then in 2020, we had a COVID pandemic started. So it's a first resilience test to the very new, very young health financing system. And of course, the year like it's 2022 when the full-scale war started in Ukraine. So it's what is like it's your reflection on these decisions on how the house financing system should be designed in Ukraine. Does it really prove to be like it's the right decision? So it's what is your, like it's a reflection on what is happening now when like the country is in a full-scale war, different parts of the country are affected differently.
Yeah. Absolutely, it worked to the benefit of the patients, because when the full-scale invasion started, many people lost their jobs at once. Many companies and employers that were located in the territories which were occupied very fast. So, and if we relied on payroll tax, all of those people would have lost their entitlements. So, in addition to losing their homes and their like ordinary life. So, at least in this situation, they haven't lost their entitlements. They moved within Ukraine, and they could have access in other places of Ukraine. Other thing that worked well for in this situation was national level pooling, because before reform there was the health was financed by the local governments. So. But with the national level pooling, we were much more flexible of reallocating money from one territory to another territory, and also to think strategically where we do need resources and channel them there. Another strong feature of this system, which proved to be also useful in the context of big war, is that we have the more flexible payment mechanisms, and that's allow us to focus on our priorities, for example, to channel more resources and to pay differently for such priority services as mental health in outpatient settings, for which the need is growing very rapidly, or war-related trauma, which is also very much increased in we see in our hospitals. So that reforms back then really supported us in the situation we are right now.
Yeah, thank you, Alona. And I think this is really important, not only lesson learned for Ukraine, but other countries as well. Like it's what is like that resilience proof or crisis-proof health financing system design. And of course, currently the situation is very challenging, because if we want to monitor financial protection, we cannot use like it's our usual like household budget surveys, but we need to kind of bring together different data sources and to be very creative to do that. But it's very important to continue. But let me now hand back to Natasha to continue the discussion. Thank you.
Thank you very much, Trina, and thank you to Andres and Alona for really sharing these interesting experiences. I suppose it falls to me now to cover Malta with Kenneth here. And let me first say how excited I am that for the first time we are going to have a financial protection report for Malta. Until some years ago, this could not have been imagined, and I feel a bit jealous, and I see Kenneth nodding too, when I see that Anders has been producing financial protection reports for the past 20 years. When I was involved in the first HIT report, which was an embarrassing now 25 years ago, almost, we launched it in 1999, I remember I was shocked when we first looked at this high rate of out-of-pocket expenditure, because this is not something that is immediately tangible in Malta. I can still remember when with John Silas, there he is, in 2011-12, we were working again on a HITS report, and he kept coming and saying, but Natasha, this data can't be making sense. This data doesn't make sense. We've got to look at it again. And I suppose this is a bit still where we are, Kenny, that at first glance, we have this high rate of out-of-pocket expenditure, 30%. And I remember my response to John at the time was, but don't worry, John, you know, this is a lot of people just paying a little bit and nobody really suffers. But today we know from the work you are doing that we actually have 7% of people who are facing catastrophic payment. So unpack a bit the story behind the numbers for us, Kenneth, and what needs to be done.
Yes, indeed. So, yes, this is our first attempt, first report. Perhaps it was never done before, perhaps because we had the impression, because we have universal health coverage, we don't need it. We have no financial problem, no financial protection problems. But certainly, I think now the evidence is showing otherwise. And certainly this out-of-pocket payment, 30, probably even higher now, 33, 35%, didn't come as a surprise because we already knew it. Even more so, I think the methodology actually confirmed what we already knew. So in that sense, it was quite robust. I think the problem we have with out-of-pocket payments is that it's not perceived as a problem at the political level in Malta. Precisely as Natasha said, because politically it's viewed as giving people a choice. And for them, it's all about choice. And the choice basically is either going to the public sector, which is obviously free at the point of use, or having the choice to go privately, certainly for GP, you know, for family doctors, and even to see specialists. And they've used the argument of choice over the last, I think, 20 years now, whenever the WHO, even more so the European Commission, comes to Malta and says, listen, you have a high out-of-pocket payments, and at the political level, they say, well, but we're giving the people the choice. So I think that, but this is the very first time now that we're actually linking out-of-pocket payment with catastrophic financial spending. And this is the first piece of evidence that we have at hand now to actually go to the policymakers and say, this is a problem. We cannot continue to sustain this. So I think that's very important to realize. There are three main components for out-of-pocket payments. So it's medicines, it's visits, outpatients, private visits, and dental care. Dental care was always private. We never had a comprehensive dental service in Malta except for children and emergency dental care. And I don't really see that changing in terms of a policy approach. From medicines, we have a very unique system. We have no user charges in Malta, no co-payments, quite unique in that sense. And about 30% of our population are covered by this covered for chronic conditions. But if you're you're not part of that list, you basically have to buy your medicines fully, so 100%. So it's either 0 or 100%. And that is what is driving our out-of-pocket payments even more so. Obviously, the solution to that is expand the list. So rather having it more as an exclusive list, having it more inclusive. And there have been attempts, and there have been progress, certainly in the last 20 years, 15 years, of expanding the list of chronic diseases and getting more people into the scheme. And there have been also attempts, I mean, Natasha would remember, even myself, of reforming the way we pay for our medicines and the way people pay for the medicines. Again, but it's a very sensitive political issue and we haven't yet, but hopefully now with the evidence we'll be able to do that. On outpatient visits, that's linked to, I think, our cultural issue that in Malta we like to go to our private family doctor, we like to go to our private specialists, and although we have access to the public services, we still have that preference. The problem I see now is that we have a huge influx of migrants, documented migrants, but they're low-income migrants, so now about 25% of our population are migrants, are foreign. And they are slowly shifting now the demand on our public services, so they're actually accessing public services much more, which leaves our low-income Maltese local residents at a loss to where now to access healthcare. So my fear, obviously this has to be empirically proven, but my fear is that local residents will actually have to fork out even more money because migrants are actually hogging the system, the demand is actually increasing.
So we're seeing changing patterns of utilization basically over here. I think we should explain also that the population has increased,
yes,
probably because this was mentioned also in the context of some earlier discussion over the past 2 days. It was yesterday over the ministerial lunch, the closed ministerial lunch, when we were talking about emergency services and the overwhelming of emergency services. And 2 points that were made across the table were in certain countries that have experienced a sharp population increase, as well as this movement of people and the issue that sometimes migrants might bring with them different patterns of service utilization, which I think you are explaining over here. The other element is that when health service delivery, public health service delivery starts to fail, and in the context of the COVID pandemic, we see many countries with large backlogs, then of course there is this shift to the private sector. Do we know who the 7% of the population facing catastrophic expenditure are, for example, in terms of age groups?
No, I think we need to delve deeper into the data. I think the data is still not, there isn't still enough evidence or data to actually break down this 7% into actually categories.
Because my fear would be that pensioners, for example, because of the insufficiency of pensions to keep up with cost of living.
We know the overall figure, but we don't know the breakdown. So that's something that we need to look into.
We're coming to the top of the hour. One last quick question. In your capacity as co-chair of the Health System Performance Assessment Group, you heard from Maya this morning about health system performance assessment. To what extent is financial protection a key objective for member states when they look at health system performance assessment? What I can say is that as WHO, we're looking forward to GPW14, and I'm glad to say that so far member states have made it quite clear to us that they would like to maintain financial protection as one of the key core objectives.
Yeah, obviously, financial protection or financial fairness, as it was originally coined by WHO, was always a feature within HSPA. But I think over time, it's really moved on to looking at the overall financial spending. So, percentage of GDP, the figures we've seen also this morning in terms of the financial reports we've seen. So I think HSPA really contributes to sort of as proxy to look at financial protection, looking at equity, access to healthcare, patient-centeredness. So many indicators don't measure financial protection directly, but indirectly to other dimensions, and even newer ones that we're seeing now. So unmet need. We have a lot of work on equity and looking at inequitable, obviously, access to healthcare and geographical variations, which obviously the underlying cause of that is many times the lack of financial protection within the population. So, but having said that, I think mainly through the work actually that has been going on with the Barcelona office, there has been a renewed interest into actually looking at specific indicators that really reflect this reality more even within the new frameworks that are coming up through WHO Observatory and even at a national level now. So I think there's a renewed...
Very good, and we're counting on you to keep the focus on financial protection also in the HSPA group. We've come to the top of the hour. They're brilliant panelists. I'm sure you've got many questions for them. Find them over coffee, and don't forget to see the story of the elderly Estonian couple, which is downstairs just by the coffee bar. It's beautiful. Thank you so much, Tamas, Sarah, Andres, Alona, Kenneth, and Trin. And thank you for joining us.